presentation, we'll offer a brief overview of exposure therapy. Exposure therapy is a behavioral approach which is widely used within cognitive behavioral therapy. To understand why exposure therapy works, it is important to know the connection between classical conditioning and anxiety disorders. Individuals with anxiety disorders associate non-threatening stimuli with either traumatic events or imagined future catastrophe. They have learned to react to the formerly neutral stimuli as if it is an actual threat. Classically conditioned responses are recorded deep in the limbic center of our brain. When we perceive something as threatening, a pre-recorded emotional response is triggered, which overrides rational thought. Cognitive restructuring may also be used in conjunction with exposure therapy as part of cognitive behavioral therapy. From a behavioral perspective, specific phobias are maintained because of avoidance of the phobic stimuli. Thus, the intervention would involve exposing an individual to their phobic stimuli in order to create the realization that it is not as terrible as they imagined. With repeated exposure to the stimuli, an individual's response to it will decrease. This mechanism is referred to as habituation. For example, an individual with a snake phobia may experience a stress reaction just looking at a photo of a snake. Repeated exposure to the photo would eventually weaken the association between the photo of the snake and the anxiety response, thus replacing one form of conditioning with another. Exposure therapy may be used for a variety of anxiety disorders, such as specific phobias, social phobias, obsessive-compulsive disorder, post-traumatic stress disorder, social anxiety, generalized anxiety disorder, and panic disorder. Major tenets of exposure therapy are mirror those of CBT and include the theoretical assumptions that inappropriate behavior arises as a result of misperception or misinterpretation of the environment during the process of learning. Beliefs, expectations, and perceptions affect how an individual behaves, and behavior is learned and maintained through positive and negative reinforcement in the environment. Some models used for exposure therapy include in vivo, guided imagery, systematic desensitization, virtual reality, and narrative.
In graded therapy, clients are gradually exposed and desensitized to a feared situation. This is also called desensitization therapy. In flooding, it's based on principles of the respondent conditioning. It's also referred to as prolonged exposure therapy. In exposing patients to painful memories with the goal of reintegrating their repressed emotions with current awareness. Systematic desensitization is based on a principle of classical conditioning. In this therapy, you remove the fear response of a phobia and substitute a relaxation response to the conditional stimuli, gradually using counter-conditioning, using the rank system of least fearful to the most fearful. In virtual reality, the therapy uses visual stimuli, 3D audio, vibrations, and smells. It's based on a narrative therapy and used in many forms of trauma. With in vivo, it's based on direct confrontation of a feared object, activity, or situation. An example would be revisiting a rape site or giving a speech for those afraid of public speaking. Guided imagery is based from behavior modification, much like in vivo exposure, but the client uses images in the mind. Clients can also use a relaxation technique to process negative thoughts. In narrative therapy, the client constructs a chronological narrative of their life story with a focus on the traumatic experience. Fragmented memories are transformed into a coherent narrative. Unconditional positive regard is a key component of this type of therapy. Some of the settings for these different types of therapy include individual therapy sessions, where most, if not all, of the prior therapies can be used. Group therapy sessions, where often narrative and in vivo are the two preferred therapies. Psychiatric wards are also used as a location where they treat borderline personality disorder using narrative exposure therapy. In-home sessions are also used for the comfort of the client to treat phobias, OCD, and traumatic events. Community sessions can also be used for OCD, phobias, and trauma. Examples would be taking someone to a bridge to have them walk over. Client homework is big in this type of therapy. It can be used to have the client go home and use pictures, photos, or actual items in their home to become comfortable with them being within their vicinity. And finally, VA medical centers are a large location throughout the United States that are used for trauma and PTSD. They treat with virtual reality, guided imagery, and narrative.
Effectiveness. According to the VA, prolonged exposure therapy is a golden standard treatment for PTSD that has been subject to many clinical trials supporting its effectiveness in reducing PTSD even along complex and comorbidity patients. Exposure therapy has proven to be highly effective in reducing PTSD symptoms associated with a variety of traumas, including combat, non-combat, and military sexual trauma. Also associatedly reducing comorbidity symptoms that occur with PTSD, including general anxiety, depression, guilt, and anger. According to the Psychiatric Times, exposure-based therapies are highly effective for patients with anxiety disorders to the extent that exposure should be considered the first line evidence-based treatments for such patients. The effectiveness of exposure therapy when working with anxiety disorders was captured in several studies which showed a single session of in vivo exposure had a reduction in fear, avoidance, and overall level of impairment by 90%, and no specific phobia by 65%. This was after post-treatment follow-up with the average of 4 years. Cognitive restructuring works with dental phobia and claustrophobia, but there is no evidence-based that cognitive reconstruction works with other phobias. When it comes to exposure limitations, exposure therapy with or without relaxation, some studies have shown that relaxation is counterproductive because relaxation can outweigh the response of exposure. Also is re-traumatization and underutilization of exposure therapy. We will demonstrate the application by this using graded exposure in a third session, using external clues which will be introduced with the use of a toy replica of a snake on different levels of exposure, such as distance, closeness, and contact exposure.